So good morning all. I would first like to thank Veena ma'am for giving me this opportunity for this topic, Exotropia Unraveled, Insights into Clinical Features and Management. So to understand what exotropia is, it is only a divergent strabismus. It is more common and prevalent in Asian countries than esotropia. It appears to be seemingly straightforward in management and diagnosis, but yet it's really frustrating to manage when we get into it. And risk factors include substance abuse during pregnancy, premature birth, perinatal morbidity, genetic abnormalities, uncorrected refractive error, and family history. So this was a 4-year-old child whose parents came to us that the child has exotropia since birth. But on further evaluation, we saw that there was only an appearance of exodeviation, but the eye was actually aligned. If you can see, both the pupillary reflex are in the center of the pupil. The light reflex is in the center of the pupil. So this is nothing but pseudoexotropia. It is common when there is wide interpupillary distance, positive angle kappa with or without other ocular abnormalities, hypertelorism where the eyes are widely placed, and visual axis parallel. The visual axis is parallel in all position of gaze, and BSV is usually present. So coming on to the classification of exotropia, as any strabismus, it is classified as comitant and incomitant and secondary. So comitant includes intermittent exotropia, infantile exotropia, and decompensated microtropias. Incomitant strabismus includes restrictive strabismus, restrictive exotropia, paralytic, like oculomotor paralysis, paresis, and DRS. Secondary include sensory, where one of the eye has a poor vision and that deviates, and consecutive, post-surgery for esotropia, if there is a exotropia, then it is consecutive. So these two terms are often confused by PGs. So let me describe what exophoria means. It is only a latent outward deviation of the eye controlled by fusion under normal binocular viewing conditions. It is detected only when the binocular vision is interrupted, either by monocular occlusion or by alternate Kappa test. These are usually asymptomatic and don't require treatment. The treatment is only needed if they become symptomatic. So these exophorias can progress into exotropias. Now, what is exotropia? It is a manifest outward deviation of the eye. That means the deviation is always visible. So it usually occurs if the exophoria decompensates. The most common form of strabismus is intermittent exotropia. And its onset is usually in childhood, between 6 months to 2 years of age. It is more common in females. Now, the stages through which this intermittent exotropia follows is exophoria initially, which then becomes intermittent exotropia, and finally, constant exotropia. So what are the clinical features of intermittent exotropia? Usually diplophotophobia. What is diplophotophobia? It is that when the person with IXT is exposed to strong light, the exophoria may decompensate into exotropia. So the child would start seeing double. To actually avoid that diplopia, the child actually squeezes his eye. So this reflex is actually called as diplophotophobia. What is micropsia? When the objects appear smaller, it is called as micropsia. And this can occur as a feature of IXT when the child tries to control his exodeviation with accommodative convergence. Asthenopia, in process of controlling the exotropia, sometimes the child may experience eye strain, blurring, or headache. So the exotropia, intermittent exotropia, has around 4 phases. The first phase is only exophoria. It is asymptomatic. They have no problems. Stage 2 is intermittent exotropia, where on and off there is deviation. It is more prominent for distance, but for near, the child is well controlled. In third stage, the exotropia appears for deviation for distance, and phoria appears for near, and the child may have a slight suppression of the binocular single vision. And coming to stage 4, it is constant exotropia, both for near and distance, and the binocular single vision will be nil. Burians has classified the intermittent exotropia into 4 types: the basic type, the divergence excess type, the pseudo-divergence excess, and convergence insufficiency. What is a basic type? When the deviation for distance is equal to near, then it is called as the basic exotropia. Divergence excess is when the distant deviation is more than 10 prism diopters of near deviation after monoocular occlusion. Then it is divergence excess. What is pseudo-divergence excess? It is actually when initially the deviation for distance is more than near, But after monoocular occlusion, it becomes equal to near. So this is actually a pseudo divergence excess. And convergence insufficiency is when the near deviation is more when compared to distance deviation by by 10 prism diopters or more. So examination of exotropia is any case. First, we have to take history. As I had mentioned the earlier risk factors, they have to be documented. Then then visual acuity with age appropriate chart should be done. Cycloplegic refraction is must in any case of strabismus. Anti-segment examination and fundus examination is also very, very important. For example, this case had exotropia. The child looks absolutely normal with only an exotropia. But when we went and looked back to the fundus, patient had Strasma syndrome, where he had medullated nerve fibers, amblyopia, and sensory exotropia. So the management completely changes. So a complete fundus examination is very, very important. Coming to cover test, it has to be done for both near and distance, and the deviation should be measured in all gazes with both for near and distance. And BSV and stereopsis have to be monitored because this will give us a clue to whether the strabismus is progressing or not. So if on examination we come across that the deviation for distance is more when compared to near, then we should do an occlusion test. What is occlusion test? We just patch one of the eyes, more commonly the dominant eye, for an hour. And then without allowing the child to fuse, we have to check the deviation. In many cases, the distant deviation usually becomes equal to near, that is the pseudo-divergence type. But in case it doesn't become, then we go ahead with the next test, the +3 near add test. So then in these cases, if the distant deviation is still high, then this could be a case of high AC by A ratio. So these cases at any point of treatment may need bifocals, maybe before surgery or after surgery. So this has to be brought to the notice of the parents even before the surgery. So to summarize the types, so any case, when they come with the IXT, we have to first evaluate whether the distance angle is greater than near. If it is not, is the near angle greater than distance? If it is not, then it is basic type. If the near angle is more than distance, then it is convergence insufficiency type. So then we go ahead with, if the distance angle is greater than near, then we go ahead with monocular patching. With monocular patching, if the angle is still more, then we do the AC by A ratio. If the AC by A ratio is still, like if with the +3 add, the XT is better, then it is a case of exotropia with high AC by A ratio. If the XT becomes is same, then it is the divergence excess type of exotropia. So now we have to assess the control. Now, why do we assess the control? It will give us clue as to how we are going to treat the child, whether we have to start with, to understand whether it's progressing, or we can just observe the child for some time. So what measures to assess the control would be subjective measures where we take histories. There are many scoring systems, which I'll talk about in the next few slides. And there is an objective method where we check the distance stereo acuity with Lang's chart, near stereo acuity with TNO chart, and DSV for both near and distance with Wirtz 4 test. So this subjective test is when we assess the home control and office control of the child. So home control, we ask the parents how many times in a day they see the deviation, whether 50% of the time the deviation is there or not. And based on that, we give some scoring to the child. And similar is done for office control for both near and distance. And we check if the alignment is immediately after dissociation, or it is with a blink, or if it is after prolonged fixation, or it manifests spontaneously. Based on this, scores are given to the child, and a score greater than 3 warrants treatment in some form. Less than 3 can be observed because it is not, like it is very less. So we can observe those cases. Now, what are the red flags of progression of intermittent exotropia? One is the increase in size of deviation. When there is loss of fusional control, when there is a development of suppression of BSV, then development of convergence insufficiency, or loss of stereopsis. So if these red flags of progression are noted, then we should start some form of treatment. So what are the non-surgical management? As like Anjali has also stressed on that we have to correct the refractive error first. So after correction of refractive error, if these angles are still there, but they are smaller, then we just observe. But if the angles are slightly big, we even try with alternate occlusion to improve the control. We can also give over-minus glasses, orthoptic exercises, and prisms. So what is over-minus therapy? As Dr. Akila had also mentioned, it will induce accommodation and thus accommodative convergence. It is very, very useful in younger children. And it is usually the power is usually prescribed symmetrically. About 1 to 2 diopters can be tried, but we have to be very careful to watch out for esophoria or worst esotropia in these cases with glasses and small possibility of inducing myopia, as even sir had told about this. So second trial would be convergence of fusion exercises. These are orthoptic exercises or computer-based software, but these are not very effective in children. Why? Because they don't understand the exercises or they're not very used to doing it. But it can be tried as a temporary measure only in adults. In some children above 8 years, we have tried, they sometimes work. But this is only a temporary measure. It will only help us to increase the fusional control and not the decreasing exodeviation. And moreover, they can be repetitive and boring over a period of time. Prismotherapy can be tried in smaller angles with base in prisms. So there is some have described that half of the exodeviation can be corrected with prism, and rest half and the remaining exodeviation can stimulate the fusional convergence and thus can control the exotropia. Up to 6 to 8 prism diopters can be tried in front of each eye, and Fresnel's prisms can also be tried about 15 prism diopters in front of each eye. Now, if these procedures don't work, or we see that there is worsening of control, increase in angle of deviation, decrease in stereopsis, if the patient complains of double vision, which affects his day-to-day life or cosmetic demand, then we go ahead with surgery. Now, what are the nuts and bolts of surgery in exotropia? The timing of surgery. If well controlled, better to defer surgery. If a younger child, the measurements are not reliable, it is better to wait till we get reliable measurements and then proceed with surgery. The most appropriate age group to operate exotropia would be 3 to 7 years of age. So what angles do we plan for the surgery, like post-op? So 5 to 10 prisms or diopters of overcorrection is usually planned. And these overcorrections should not be tried in younger children, as it can cause monofixation. In adults, we usually plan to make them orthophoric. And in myopes, we have to slightly undercorrect. What are the procedures of choice? It can be either unilateral or bilateral. So as it's exotropia, we weaken the abductors and probably strengthen the adductors. And appropriate surgery for pattern should also be done. So many surgical procedures have been described. So as I said, we weaken the abductors. So lateral rectus recessions can be done, or unilateral R&R procedure where lateral rectus recession with medial rectus resection can be done. And in some cases, we can even do augmented bilateral lateral rectus where we just overcorrected by 1 to 1.5 centimeters. And these surgeries are mostly described for basic type or stimulated divergence excess type. But in divergence excess type, it is better to do the lateral rectus more than R&R procedures. So in many cases, we have even, it has been also been described that we can do Faden's on the medial rectus and just weaken the medial rectus because Faden's suture helps to weaken the muscle. In convergence insufficiency type, it is actually the most difficult to plan surgery, and there are multiple surgical options and procedures described, and it's still confusing as to how we are going to be able to manage it perfect. No case, it is perfect. So newer procedure which has been described in these cases are slanted recessions, where bilateral lateral rectus is recessed in a slanted way. We plan for the distance deviation. The upper pole is placed is recessed with the distance deviation, and the lower pole of the lateral rectus muscle is recessed with near deviation. Improved R&R with lateral rectus for distance and medial rectus for near has also been described, but all these are controversial, and we don't, and the outcomes are also actually very variable with all these procedures. So our most dreadful post-ops are undercorrection or overcorrection. If in immediate post-op period, we find that there is a motility limitation with undercorrection or overcorrection, then slipped muscle should be suspected. If there is no motility limitation, then we can just observe with patching. And if this persists beyond 6 months, then we have to plan a resurgery. In late post-operative period, if there is motility restriction. So what is Cooper's dictum? He described that if the muscle is tight, if the motility restriction is there, then it is better to operate on that muscle where restriction is. So if there is motility restriction, it could be because of LR scar or LR advancement can be tried. Without motility restriction, then medial rectus can be resected or unilaterally or bilaterally. So coming to infantile esotropia, as infantile exotropia, this also the onset is before age of 6 months. There are usually no secondary causes to this. The features are same as infantile esotropia, like there are large angles, DVD, inferior oblique overactions are there. So we see large V patterns. And these cases, because the angles are very large, usually surgery will be needed. And sensory exotropia, when there is poor vision in one eye, that eye tends to deviate. In children less than 5 years, usually this deviation is esotropia or exotropia with equal incidence. In children older than 5 years, more often exotropia is encountered. So the causes for poor vision in one of the eyes in children are like, for example, ptosis, any media opacities, or any refractive and isometropic amblyopia and other posterior segment diseases. So these are usually large angles, and we usually do a Krimsky's test, where we placed increasingly strong basin prisms over the fixing eye, drawing the non-fixing eye towards the primary position. Usually because there's poor vision in one eye, fusion is completely lost, and treatment is only for cosmetic reasons. So we can postpone the treatment. It does not require immediate surgery, and the chance of redrift, because any eye which is again having poor vision, it may redrift even after surgery. So one more entity I wanted to emphasize was consecutive exotropia. So it is exodeviation which is preceded by esotropia. It can occur spontaneously at times, but more commonly by surgical correction of esotropia. So predisposing factors may be refractive error and amblyopia. And it is more common with, it is rare with accommodative esotropia and common in partially accommodative esotropias. So these cases, we have to go and do a revision surgery. In cases which are already operated, we have to do a revision surgery and see if we can do unilateral or bilateral MR resection and recessions and LR advancements. So this is just, we feel that exotropia is very easy to manage and we get clear-cut cases, but it's never so in the OPD. So I would like to present a few cases. It will take another 2 minutes. So this was a child, a 14-year-old child who presented to us with exotropia for near and distance, where near deviation was 45% diopters and distant deviation was 30% diopters. So what do you think what type of exotropia is this? When near deviation is more? Okay. So in this case, we did a slanted recession where upper pole was corrected for distance. The upper pole recession was correcting the distance deviation and lower pole for near angles. And post-op, we saw both the patient was ortho for near and distance with no distance near disparity. So this was a case. Can anyone tell me the diagnosis? It's very easy. Clear cut. I'm pointing out. So this is a case of XTDRS where there is abduction restriction and upshoot. Okay. So, and in straight gaze, the patient has XT. So what did we do? So we did LR recession with Y split. So now you can see that the upshoot has completely gone and patient is relatively ortho in straight gaze. So this is the third case. Can anyone tell me the diagnosis? So you can see that the elevation is slightly restricted in the right eye. Even the depression is restricted. But horizontally, there's no restriction. This is a partially recovered third nerve palsy. So what did we do? We did a basic R&R procedure to correct the exotropia. In these cases, the patient had diplopia in all gazes. So in these cases, we take that adults don't need upper gaze. Up gaze diplopia can actually be ignored, and we correct the straight gaze and down gaze diplopia, which is because that is more effective for the patient's day-to-day life. So we did R&R in the affected eye, and we put a fade-in suture on the inferior rectus in the left eye, so that we weaken the left eye inferior rectus also, and thus it would become equal weakness in both the inferior rectus, and thus making the down gaze diplopia disappear. Thank you.